Morning. Before we get started this morning, I just want to go through a few housekeeping items. Number one, we are broadcasting live, so for people in the audience, please use the microphones to ask questions. And to know that the recording is always available online for viewing. Please like or comment or subscribe to and share our YouTube channel. For our viewers who are watching this morning, if you would like to submit a question, text DeBakey to 37607. Again, that's DeBakey to 37607. I do want to tell everybody about a few upcoming activities on our schedule. We have our Heart of a Woman conference here on January the 7th, so just on Saturday. So hopefully we'll see a lot of people there wearing their red to support our Women's Heart event. We also have the Houston Heart Failure Summit on February the 15th. And it's actually very, I think, appropriate that this year's Heart Failure Summit is on hypertrophic cardiomyopathy. So you're going to get a teaser today into some of the hypertrophic cardiomyopathy. And then we'll make sure that our summit will know about the video option on the YouTube channel to be able to also partake in Dr. Mckenna's discussion from today. Also, we have the Robotic Surgery Summit on March the 11th, so mark your calendars for those events. As we get started today, it really is my true pleasure to introduce Professor William Mckenna. He is a world-renowned cardiologist and leader in the field of inherited cardiomyopathy. Professor Mckenna is an Emeritus Professor of Cardiology at the University College of London and formerly held the prestigious British Heart Foundation Chair of Molecular Cardiovascular Sciences. His groundbreaking research has contributed significantly to our understanding of cardiomyopathies, including genetic and the underpinnings of hypertrophic, dilated, and arrhythmogenic cardiomyopathy. With over 540 peer-reviewed publications, not really sure when you slept, Professor Mckenna has shaped modern cardiology through his pioneering work in genetic testing, risk stratification, and clinical management of inherited heart diseases. He's received numerous international honors, including the Silver Medal of the European Society of Cardiology, and has delivered distinguished lectures worldwide, such as the Sir William Harvey Oration and the Henry N. Newfield Keynote Lecture. Beyond his research, Professor Mckenna has played a pivotal role in advancing cardiovascular genetics, serving as the founding president of the UK Association for Inherited Cardiac Conditions. Also, on a personal note, you will not find a more humble and warm and welcoming person than Dr. Mckenna. He has truly been not able to share his wisdom, but more importantly in this day and age, his time and his kindness. So please join me in welcoming Professor William Mckenna as he discusses genetic advances in hypertrophic cardiomyopathy, informs new management algorithms and treatments. Professor Mckenna.
Cindy, thank you for very kind words. It's a pleasure and a privilege to actually be here. Hopefully this talk, which will focus on genetics and how the genetics are influencing management, will be a good kickoff to a week Saturday summit, or not summit, workshop. So I think we're all vaguely familiar with most of this, and I think as physicians we have been utilizing technologies, most of which were developed by others, but if you go back on the roughly 70, 80 years of hypertrophic cardiomyopathy, I think we started off with a stethoscope and a physical examination, and then 12-lead ECG, imaging with M-mode, 2D, and then MRI. We've developed some therapies that were targeted, theoretically targeted, such as beta blockers, calcium antagonists, and they have not done a great deal, but they're not targeting actually basic mechanisms, and that's what we're going to try and head to today. Major problem, obviously, is risk stratification, sudden death. And I think if you have a child with the condition, that's one of the things you're clearly worried about. And I think between drugs for atrial arrhythmias, amiodarone, but particularly risk stratification and the defibrillator has made a difference. But we haven't really fundamentally developed therapies that go after the underlying etiology and pathogenesis of the condition. And that's I think we're in a new and exciting era. So the two bottom lines here, mutation analysis and novel therapies, is what I'll be talking about. It's interesting, if you read reviews on hypertrophic cardiomyopathy, they've changed over the last 40 years. So for many years, hypertrophic cardiomyopathy is a disease of hypertrophy, diastolic dysfunction, and yes, there's hyperdynamic systolic function and obstruction. And when we started in 1960, it was the obstructive component, the murmur, the gradient measured a catheter that excited people, trying to understand mechanisms. We've shifted away, and for many 80 years, it was a disease of hypertrophy. Now, with these new therapies and the septal reduction therapies, if you read reviews, now it's a disease again of hyperdynamic function, systolic function, and obstruction. And I think when we will get into trials and some of what's going on on the frontier, but it's important to remember, on the right-hand side of the slide is, I think, when the FDA and your company's getting endpoints and outcome measures, these are the outcome measures that really matter more than the gradient or other aspects that we as cardiologists tend to focus on. So I'll come back to what the patient's perceptions are. I think you could sort of summarize very briefly, but I think the modern era potentially begins with the genetics, and the genetics begins. The pedigree on the upper left is published, Peter Paré, 1960-61, familial cardiovascular dysplasia. And Peter Paré is a very eminent, he was chest physician in Montreal at McGill University, and he saw a young man who had cardiac symptoms and breathlessness, and he took a family history, and that family history resulted in that pedigree. And he was able to trace this family that had come from northern France in the 1680s to Quebec. And because there was never a sort of Oliver Cromwell or a revolution in Canada, the churches actually contained birth certificates, baptismal certificates, marriage certificates, death certificates, and he was able to track the family and create this pedigree. And when he retired, this is of interest to me because I came from the same village as this family, and he was my boss in Montreal at McGill. So when he retired, he passed the family on to John Goodwin, who was my boss in London. And this is the lower pedigree is what we studied in collaborating with John Jarko and the Zeidman Laboratory. And the genetic work was done in the Zeidman Laboratory. And that was the first gene as a mutation in beta-myosin heavy chain in 1990. And I guess you could say 1990, and we're now in 2025 or 20. Why so long? It's been a very slow course to really utilizing the genetics that we have had potential access to. It was pretty quick to find other sarcomeric genes. You see the schematic from an editorial, but a review by Paolo Spirito and others. And they very quickly identified mutations in the thick and thin filament, mostly at binding sites between myosin and actin and the proteins of the thick filament, of the thin filament. Importantly, and one of the things we didn't appreciate in 1988 when we were doing the linkage, doing the study, is that family that I showed, every single person who carried the gene actually had an abnormal ECG, an abnormal echo by the age of 15. So they were complete penetrance and full expression prior to adult years. This was that, and that we're fortunate in that because the earlier attempts to find families, you were beleaguered by the fact that the incomplete penetrance was a problem. So you couldn't say someone didn't carry the gene if they had a normal ECG echo at age 17 or age 20. Clearly, I'll be talking mainly about sarcomeric disease, but certainly in that era, and when I went to medical school, this was like memorizing a telephone directory, these other causes of hypertrophic cardiomyopathy. Now they're actually very relevant because we know the genes, and for most of them we have therapies. So it's important to just put this in context that we're talking about one type of hypertrophic cardiomyopathy. We'll also, when we get to the gene therapy, be talking about a storage disease, Danon disease, which I don't think fits into the sarcomere, but it's been lumped under the umbrella of hypertrophic cardiomyopathy. On the genetics, I think there is a lot going on right now, and this doesn't necessarily pertain to what I'm going to talk about with myosin inhibitors and gene therapy, but I think it's worth bearing in mind that we have lived with monogenic, Mendelian dominant, sarcomeric, and as I mentioned, the syndromic metabolic causes of hypertrophic cardiomyopathy. What's happened in the last 10 years is structural and regulatory genes, and these lists are not complete, but FHOD3, TRIM63, and alpaca-3 are three of other genes, and they probably account for somewhere between 10 low-end and 20 high-end of what we would label as hypertrophic cardiomyopathy, not caused by a sarcomere mutation. The other I was going to say vogue, that's not correct, but certainly an interest is looking at polygenic determinants of disease expression. I think one of the things that's beleaguered us is that you can have a particular mutation in a family and the disease expression is extremely variable. So what is the cause of this variation? Are there other genes? Sometimes there's a second gene, that may be 2%, 5%, but there's oligogenic and polygenic determinants, and that is being emphasized. There's a constant, there's a lot of work going on, putting together, and obviously you need big registries for this, but when you have an allele frequency of between 1 and 5%, to what extent do these other variants, which are common in the population, contribute to variation? And they do. But I think that remains to be fully established. It's beyond the scope of this talk, which largely is going to focus on myosin inhibitors and gene therapy. So with understanding of the genes, we should be beginning to understand the potential therapeutic targets and that result in the phenotype. And again, I would highlight, why have we been so slow from 1990 to 2020, say 2020, in getting into better therapies? One, early on, after the first genes, there were some genotype-phenotype studies published, and they suggested that this particular troponin mutation was associated with sudden death, or this particular myosin mutation was associated with adverse prognosis. It became very clear, and you'll recognize that publishing, if you can go against the flow with a paper or experience that is different, it's easier to get published. Very quickly, it became clear that these were selected populations that had been resulted in so-called genotype-phenotype relations. And I think the community developed a skepticism about early genotype-phenotype. The other thing is that cardiologists were not the greatest at taking a family history. and we certainly don't do it to the same extent that the geneticists do. And it was one more thing, we didn't have genetic counselors in the clinics, but basically we didn't actually do gene testing. So if you look at major referral centers, a generous guesstimate is that 20% of patients are actually getting a gene test in some of the major referral centers, in not just in America, but worldwide. And there's logistics, there's genetic counseling. But in the end, you could be critical and say, well, what are these knowledge of the gene, is it actionable? And it's taken us time to get the data sets to show they're actionable. But this slide is actually survival curves. If you look on the lower left, there's decent numbers of patients. There's 6,000, 7,000 patients with the commonest sarcomere genes, myosin heavy chain, myosin binding protein C, troponin T, and troponin I. So decent sized data sets. And yes, there's statistical differences, but they're not actionable clinically. You're not going to put an ICD in or have an advanced heart failure treatment because of those differences. So this is what we've lived with. However, those curves lump everybody together. All troponins are all lumped together. All myosins are lumped together. If you then begin to look at specific mutations, and here the classic one is the troponin T hotspot. So the alleles encoding amino acids 92 to 95 are clearly and were recognized early, and that was what we published early on in the mid-90s in New England. They clearly have an adverse prognosis. So, but in relation, there's a founder gene with several hundred patients in Spain and elsewhere, but mainly in Spain, the 271. And if you have a 271, basically very few people die suddenly. It's a very different disease expression. So this highlights the differences, and these would be actionable. If you then go down boil it down in terms of gender, and you can see on the bottom the color coding. The blue is sudden death, effectively, or ICD discharge, and the reddish colors are heart failure related outcomes. Sorry, and so here you break it down into male and female, and along the top would be female with a 271, and effectively she's fine. She's not going to die suddenly. And the contrasting one would be the blue, the lower curve, which is if you're a male with a hotspot 92 to 95, you've got about a 40% chance of dying dying suddenly before the age of 50. So these are actionable, and these are just some examples. You can do the same thing with myosin. You can do the same thing with troponin I. These are, and why? Well, we're getting into the kind of numbers, but we haven't got the numbers we should have because we haven't been doing gene testing, particularly the referral centers haven't been doing that. So but I think we're at a stage where we're beginning, get with the guidelines. All the guidelines say gene testing. I think we're beginning to change in the referral centers in particular. This is just an example to give you an idea of what I'm talking about. So here's a family that we published in 1990. And that small pedigree, and the 4 individuals who were deceased died suddenly as their initial disease manifestation. All were doing, one was making tea in the kitchen, another was walking to a shop to buy milk, basically doing normal daily activities. The pathologist, the local pathologist in the Midlands in the UK, looked and the coronaries were normal. He said, why are these people dying at this age? He sent the whole hearts, 4 hearts, to Michael Davis, who was a particularly renowned cardiac pathologist in the UK. And Mike Davis reported, he said, these families, this is in the publication, have myocyte disarray, the diagnostic feature, pathological diagnostic feature for hypertrophic cardiomyopathy, but their heart weights, heart mass, and there is no hypertrophy. Is this some form of non-hypertrophic cardiomyopathy? Until we find the genes, we won't know. The gene was one of these 92 to 95. This is the disarray. On the left was the 21-year-old girl, and she had that 40% of her left and right ventricle was that. And if you were designing an electrical substrate for unstable and lack of homogeneity and instability, that would be it. We looked at the 23-year-old girl and the pedigree, and that's her ECG, clearly abnormal. Her echo and her MRI were completely normal. She has had a defib put in eventually, which has never gone off. So she's been fine. But that is not atypical for 92 to 95. It's not severe hypertrophy. It looks mild in terms of all the things we measure as cardiologists, obstruction, mass, function, it looks mild. So if we move to risk stratification, and this is a summary, I think we can say that it remains the major focus, I think, as physicians and as families, and the high-risk patients can be identified. We have the risk algorithms. I'll go into this in more detail, but we can identify them. One of the worrisome things is that there is an ongoing mortality from sudden death from this condition. Why? Because even in referral centers, we do not do the risk stratification. And this is even in publications. You can tell from publications on MRI and outcome that the majority of patients haven't had a Holter. But it's an outcome study. You haven't done the risk stratification. So it's fairly obvious. The other one that's obvious is that if you don't have risk factors, you don't die suddenly. And there's always exceptions, but there are very, very few exceptions to that one. And in the publications, however, that appears in one of the MRI, or some of the MRI papers, it's because they haven't had risk stratification. So in general, I think we have an approach that works, and there's differences in the guidelines and there's differences in public between so-called experts. But on the right-hand slide are the established risk factors, which are family history of sudden death, unexplained syncope, an abnormal blood pressure response. And this is an interesting one because this was in 2 sets of international guidelines, a failure to increase your blood pressure appropriate or a decrease in blood pressure by more than 20 millimeters of mercury on upright exercise. It was commented in the guidelines that it's not specific for sudden death. No, but it identifies the low-risk cohort. So 70% of young people under the age of 40 will have a normal blood pressure response. They are very, 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 very unlikely to die suddenly. The ones who have an abnormal blood pressure response, they don't all die. But it picks up the higher risk cohort that you want to actually Holter more, look after more carefully. So it is a value in risk stratification. Other proposed things would be apical aneurysms, LGE of more than 15%, and that's a separate argument. But what's missing there is the genes. And if you think about it, it's the genetic basis. The cause has to have something, should be influencing in some way outcomes and risk. So in terms of risk stratification, just risk over time, I think from 1990 to 2000, there was relative risk. So you would say, this 20-year-old with a condition with non-sustained VT has a 7-fold increased risk over the patient who doesn't have the non-sustained VT. And that we've moved on, and became a vogue for, and more than a vogue, a useful tool of these risk stratification calculators, and the first in the hypertrophic was from our group, and then I'll show that in more detail. The other approach, it's that the risk calculator has been criticized, and the other approach is what Marty Marin has published as the enhanced ACC-AHA guidelines from a single center, and I'll show you the data on that because it's another approach, and it reflects what's probably more realistic in the United States. Another thing is the guidelines. How do we interpret the guidelines? Well, in heart failure or AF management, coronary disease guidelines actually represent. There's a lot of data, and the experts on the committees are diverse. Here, we have a lot of class 1 recommendations, but the level of evidence is almost always C. So I think that needs to be taken into account when we interpret the guidelines, and yet in a system where the legalities have something to do with how you practice, that needs to be managed, as it were. So this is what we lived with for probably 20 years until the risk calculator. And basically it hasn't changed. If you have no risk factors and you do the risk stratification, you have very, very low risk of dying suddenly. And that's probably even high, and you can legitimately reassure the patient. If you have 2 or more risk factors, you're at significant risk, and warrant an ICD. And I don't think there's any question. The problem is the majority of patients who die suddenly are actually in the middle group. And if you look at the confidence limits, it's about 1% per year, but the confidence will go from 0.2 to 2. So within that group, you're going to be putting in a lot of ICDs to people that don't need them. And that individualizes, that's the challenge, is how do we individualize? I'll come to that. But this is how we have practiced, and I'll show you how mainly the Europeans have practiced and how mainly American centers have practiced. So this is the risk calculator. The advantage of this is it's an absolute risk, and it takes into account the whole patient, not just one marker. So we see age, wall thickness, left atrial dimension, outflow tract obstruction, family history, and non-sustained VT and syncope. There are 2 patients here, and the only difference, they both have non-sustained VT, they both have a gradient. The only difference is age. And if you're young with non-sustained VT, you've got a 10% 5-year mortality, which is say 2% per year. If you're say 58, 60, it's about 1% per year. And that's pretty close to what that individual may have anyway. So this guides, and here the criticism, this is not absolute, this isn't how you make a decision. No, this is, not the wording, but it's a point for discussion. It gives the patient, the family, some idea. There are a lot of problems here, and the obvious thing we're missing is gender, sex. And that's a big difference. In almost all the genes, there's a big difference whether you're male or female in terms of risk. The other thing we're missing is genetics. But this is an approach which I think has been adopted in other conditions, in right ventricular cardiomyopathy in particular, and it's a useful approach to get some kind of system and discussion point for the patient and family. Another approach, and this is Marty Marin's paper, and it's interesting. So a referral center, it's not the 94% in Boston, 94% are NYHA class 1 or 2. So this is not a severe high-end referral population. I think if you have severe symptoms and an obstruction, you end up at different institutions. But this is, I think it's a fairly large but referral population, and 25% received an ICD. And the 25% who received an ICD were anybody with a risk factor, and I suspect a few people who are just plain worried and wanted the reassurance of the ICD. But this is not, I'm not critical here. This is the patients, some people skydive out of airplanes, and other people won't fly in an airplane with their wives because it may crash. So there's different perception. It's responding to the patient and their needs. But if you look at appropriate therapy, so probability, 5-year probability of an ICD discharge, 10%. So it's 2% per year. And of those ICD discharges, guesstimate, but maybe half of them would have been fatal. So you're into a mortality of somewhere between 0.5 and 1%. Interestingly, the device-related complications are also about 2% per year. And this is data that we published, but that, again, the appropriate shocks are about 2% per year, but the inappropriate shocks, device-related complications are much higher. And pacing I remember when we started doing pacing for DDD pacing, and the pacing experts said that the complications are much too high. That's not a good center. It's true, but putting pacemakers and devices into young hypertrophs is not the same as putting it into a 68-year-old who's had an infarct. So this hasn't changed dramatically in terms of complications, inappropriate shocks, or appropriate shocks. So it's a balance, an issue. So what have we learned about the genetics, and where do we go from here with this? Well, this is something that Hugh Watkins, Shrafi, and Redwood published from Oxford in 23 years ago. And I think conceptually it's actually quite helpful. It's a hypothesis, and if you have wild type and mutant, presumably the force velocity profile of a mutant versus wild type actin myosin cross bridging will be different. And so you will get, and this was an explanation for all the disarray, which is characteristic, and the disarray, which probably has something to do with risk of sudden death, risk of arrhythmia. And they made the analogy to the boat. And in the UK, the Oxford-Cambridge boat race is a big deal. And they recruit, it's interesting, they recruit studs from the Ivy League and from America to get in the boats to get scholarships to go to Oxford and Cambridge, or not scholarships, but to go there to row. But no matter how big and strong these guys are, the most important thing is if they are out of sync, the boat tips over. So the different force velocity profile in terms of disease. So this was the hypothesis of energy and energy efficiency that Watkins proposed. And similarly, around when the first mutation was identified, a German group, Bernhard Brenner and Theresia Kraft as the leaders, but others came, and they were German physiologists originally from Hamburg, and they came and said, could we get tissue from some of your patients? And of course, you can't get meaningful tissue from the heart, but beta-myosin heavy chain is expressed in soleus muscle. So we said, of course, and we went through it. Now, I very naively thought that, the amount of tissue they would want would be, sort of like a punch biopsy or something. And they said, we've done this on ourselves. And this is the control data. There were three individuals. And what it is, it's a skinned single muscle fiber from the soleus muscle, which expresses myosin, which is whether we selected patients with myosin mutations. They had 19, in the control data on themselves, they had 19 skin muscle fibers. And each experiment is several months. Like the detail and care for this was incredible. And the three controls were not 3 volunteers, 3 fellows, 3 medical students. They were 3 senior authors, and which I thought was pretty good. And then when you did patients, and this they did a number of our patients, but when you look, this is one patient that with this particular myosin mutation, and you see there's a shift in the left. So this is a calcium sensitivity curve, and there's an increased sensitivity. So it's very increased sensitivity. And when you look down at the bottom, the calcium concentration, so it's exact also, these are low, 7 and 8 are actually low calcium concentrations. So at calcium concentrations where you wouldn't expect contractile force, you have ongoing force developed. Is this the sort of analog and basically of what we see clinically, where if you do a time activity curve, you see it normally in normals, you'll see that the bottom at end systole is maybe 30 milliseconds. In these people, in hypertrophs, it's 60 to 90 sometimes. And there's ongoing, is it inefficient, continued inefficient contraction or failure of early relaxation? But regardless, is this that what we're seeing? Because you're getting force development at calcium concentrations you shouldn't see. And this becomes particularly relevant in the myosin inhibitor world, where this is James Spodich is a scientist. He developed a laser tweezer, and he could take, instead of a big chunk of muscle, take a single myosin molecule and measure force development at different calcium concentrations. And here he's measuring a measure of force, now ATPase activity. And this is a summary, obviously, of the hypertrophs with the myosin mutations had increased sensitivity. The dilateds with a myosin mutation had decreased. But from this arises the concept of myosin inhibitors. And one of the things which surprised me was the fact that at any one time, the majority of actin myosin cross bridges are resting. So for argument's sake, say there's about 25% active in the heart. In hypertrophic, it was higher, and in dilated, it was lower. So the concept of myosin inhibitors to decrease the number of cross bridges is how this new therapy arose. And this is a summary of some of the trials. Yeah, this is a summary of some of the main trials, and I think there's been a lot of work done on this, but if we focus on the Explorer, which was mavacamten, and then subsequently on the Sequoia, which was avacamten. So these are two drugs, both developed by Cytokinetics, which was James Spodich's company. One marketed through MyoKardia and Bristol Myers, the other through Cytokinetics. And there's more data, and the data's ahead in terms of Explorer. And I think, but basically these are phase 3 studies in patients with obstruction, significant symptoms, exercise limitation. And the trials have been basically successful. They've reduced gradients, they've improved symptoms, improved exercise capacity. Somebody pointed out to me that the up arrow on VO2 for Explorer with mavacamten should be the same as avacamten. It's 2. There should be 2 arrows, but the magnitude of gradient reduction has been similar in both. So these have to be seen as successes. And this is the data from the Explorer trial. This is mavacamten, and this was published by Jacopo Olivato in the Lancet 4 years ago. And if you take a look at the top left, bottom left, and bottom right, those are basically this. The top left is exercise obstruction, bottom left is resting obstruction, and then the bottom right is Valsalva. So different forms of provocation. And you see that patients receiving MAVA actually have preserved, they've maintained, and they're very different than placebo, where the gradient hasn't persisted. So you see a decrease in the gradient on MAVA, and it doesn't matter whether it's resting, exercise, or Valsalva. Importantly, in this review, and these slides come from a review by Perry Elliott, which I think is quite nice because everything's in one place, but he shows the top right ejection fraction. How are these drugs working? They're working effectively by decreasing ejection fraction. What's the risk? Decreasing ejection fraction. And when this data was presented to the FDA, someone said at the FDA that, we see lots of presentations from companies, and very often the drug doesn't do anything like the company says it does. This drug does exactly what you say it does. It decreases systolic function, and therefore you can't do phase 1, you can't do volunteers, and it restricted but it also highlighted safety as a major component of how these trials were done. So you see ejection fraction hasn't changed, and if you look at both of the trials, the odd patient got into trouble and had to be stopped because of too great an effect on ejection fraction and incipient heart failure symptoms. This is the similar data from the aficamten study, and again, it's very similar. On placebo, there's no change, and with therapy, there's a significant decrease. And here, in this particular trial at 24 weeks, they stopped therapy and they rebounded to the gradient that you had before. So these drugs, myosin inhibitors, are decreasing obstruction, they're decreasing gradients. And this is a kind of a nice schematic from one of the papers. If you're trying to read some of these trials, and so much of the data is in supplementary material, and you fumble through trying to find out who the patients really were and what really happened, with aficamten, they somehow managed to get a complete November issue of the Journal of the American College, so JACC, and everything is in they've dissected out all of Sequoia into various studies. So it's a very nice in one journal, or one issue of the journal to be able to read. And this slide is from one of those papers. But you see on the left, you see the increased myosin actin cross-bridging, and on the right, after therapy, you see the decrease and all of the changes. So there's decreased gradient, increase in your end systolic dimension or volume, decrease in wall thickness, improved diastolic function, and overall, it's not on that particular slide, but overall improvement in everything we measure cardiologically and from the patient standpoint. To dig into that a little bit, if you look at the top left, So this is, on the top left, is a complete abolition of gradient. And by about 6 weeks, so the gradient is gone, and red is placebo, blue is active, and it persists, so it's maintained. That effect is maintained. And if we move along on the top right, you see BNP, and again, they've looked at various biomarkers, but the BNP, again, the effect, the maximum effect is around 4 to 6 weeks, and it's maintained throughout, and there's no effect on placebo. In contrast, if you then look at what the patient perceives, the bottom left is exercise capacity, and here this is a VO2, so peak oxygen consumption, and usually the greater than or less than 1.5 mils per kilogram per minute change is, as you heart failure group will know, that is considered a significant change. Now, it really depends. If you're 50 years old and you're an endurance athlete, going from a VO2 of 50 to a VO2 of 51.5 is not going to win you any gold medal. But if you're young and you've got a VO, or if you're any age and you've got a VO2 of 15 and you go to 17, that may well be a clinically significant change. So, but basically the change in the VO2s are modest, and about half the patients on active therapy on aficamten did not get a significant change as defined. And what also of interest is that there was a placebo effect, so about 20% of patients on placebo actually got an effect. And similarly, if we move to the right and look at NYHA, now NYHA class is not a great way to assess a hypertrophy. It's reasonable in heart failure, but in a hypertrophy, you can have someone who goes into pulmonary edema on Wednesday night and plays squash on Saturday. How do you grade that? And so the symptoms are, you can't, NYHA is not very helpful. But here, if you look again, you're seeing not that great a difference between placebo and NYHA class. And yes, at 20, 24 weeks, there's a difference, but there's a huge placebo effect all the way along. And that is true here. This is, again, another way of looking at it. So you could say NYHA not great. Okay, Kansas City questionnaire. And here you're trying to get down to the individual patient rather than a group statistic. So in the individual patient, you've got worse, no change, small improvement, moderate improvement, large improvement, very large improvement. Well, if you just take the large improvement, the very large improvement, about half the patients on active therapy had a large improvement or very large improvement. So good, but about half of them didn't. The other thing is that the placebo effect, again, at that end is again about 35 to 40%. And if you go down to the lower one, the Seattle Angina Questionnaire, very similar message. So yes, there's a proportion of patients have a very large improvement, but a lot of patients don't have a major change, and there's a placebo effect. And this is a throwback to the DDD pacing of the 80s and early 90s, where there was great enthusiasm for altering the sequence of electrical activation to get rid of the gradient or reduce the gradient. And there were major American trials, major European trials, and I was involved in 2 of these, and both of them we didn't really do double blind. The only trial that did double blind correctly was Nishimura and Mayo Clinic, and they had a nurse who was independent of whether that pacemaker was turned on or off, do the questionnaire, and 40% of the patients, having had a pacemaker implanted and then turned off, felt better. So and that is a significant placebo effect. It's not, I would say. So I think the bottom line on all of that is, and I come away critically looking at some of these issues because I think we've just begun to scratch the surface with the myosin inhibitors. They're doing a lot. They're doing other things. Patients without obstruction are getting a positive result. Why are the patients that are not getting a result? We're more interested in the patients who are getting a result. So I think we're in the beginning of an era where the genetic studies are beginning to inform our new therapy, and I think those therapies are of great interest and potential. Turning in the final time available here is to gene therapy, and here, what are we trying to do? Well, we're trying to attack the root cause of the disease. So everything we've been doing so far is attacking downstream or effects. This is we're attacking them down the condition. What you're trying to do is do something simple. So in the context of adeno-associated viruses, it's a single injection. You're looking at improvement in quality of life and overall function. And there's two main trials that are groups that are active right now. There have been others that have fallen away, but Rocket Pharmaceuticals with Danon disease. Danon is it's a storage disease. It's an X-linked LAMP2 mutation storage disease, skeletal muscle, eye, brain, liver, but heart. And heart determines, as a male, you have onset of the cardiac symptoms features by 10, 12, and your outcomes are a decade later, and they're usually adverse, sudden, they're arrhythmic or heart failure adverse outcomes. So that, I'll show some of the data that's done there. And then Tenaya Therapeutics have HOCM. This is more typical sarcomeric HOCM with myosin-binding protein C deletions, and again, an adenoviral vector promoter and the gene. So very, very briefly, what are the approaches? Well, we're trying to target the underlying root cause. The goal is improve heart function and outcomes. A one-time delivery, so it needs to be simple, and it doesn't change, and this doesn't change the genes in the person's egg or sperm. So important, and these are all doable. This is a schematic, and if you follow through the 1, 2, 3, 4, basically the 1 is to take the DNA out of the virus and replace in the viral capsid with the correct DNA. 2 is the injection. 3 is getting through the body to the target cell, the myocyte. And then 4 and 5 is basically uptake by the myocyte and with destruction of the virus by the myocyte and production of the protein. So this is the sequence that we're trying to achieve. Successes. Why it's been, and I would ask the question, why have we been so slow? But there's lots of successes going back, and here there's a list, but some terribly difficult diseases, but spinal muscular atrophy, large number of patients, muscular dystrophy, hemophilia A and B. So there's been successes, and if you look at the numbers down the bottom, there's 5,000 patients treated with the adeno-associated viral vectors, and there's 3,700 with a very serious spinal muscular atrophy disease. And I show that because Rocket and Tenaya both are using similar adeno-associated viral vector to what has been successful in over 3,700 patients there. What are the risks? Well, I think going to the very bottom one is it's under investigation and we don't know all the risks. So we're in a zone where we're traveling. It's like being an explorer several hundred years ago. You don't know what's around the corner, and I think being safety is paramount. And I think everybody has taken that on board, from the regulatory authorities to the companies. Other risks, though, the immune system will respond to the virus, and you need immunomodulatory therapies. There's liver inflammation usually associated with the therapies. It's presumed that you can only receive this once because the body's immune system, if you were to receive a therapy a second time. So if you get the dose wrong the first time, you can't just come back and give it a second time. So that is a limitation, and probably a correct limitation. And I guess there's the theoretical component that how do we know it's going to go to the myocyte? Why will it not go to other cells? And I think there's a lot of basic science behind all of this that has ascertained that, but that is certainly a theoretical consideration. So the Danon study has been published recently in a New England paper by Barry Greenberg. This is a quick summary of it. But there were 7 males, 5 were greater than 15, and 2 were 11 to 14. A quick response to that, when you look at some of the outcomes, is one of the patients actually had to be withdrawn and transplanted. Basically, his ejection fraction was too low. So I think these ages suggest more severe disease, and you obviously want to get in earlier if at all possible. The severe side effects one was a complement-mediated thrombotic microangiopathy. There were 3 that the steroids activated the underlying skeletal myopathy, which, again, it's a storage disease. But the one serious one was the heart transplant, which I don't think was a side effect, but is a lesson that we should be trying to get these patients earlier. And then this is the ejection fraction. So, this is the effect of the protein, which is what you're trying to show is that you're getting protein production, and they biopsied at regular intervals. You can see 12, 18, 24, and 36 months. And the one patient who's missing here, patient 5, was the one who was transplanted, but you're basically getting protein expression. I'm not sure how much you can read into the timing, because the grading with immunohistochemistry can be a variable feast, and I'm not sure that how accurate or reproducible that is, but clearly, importantly, there is protein being expressed, and the overall success in this study in terms of improved function, symptoms, was variable, and it's probably too early to really be very dogmatic about this, but there's a phase 2 study underway in this regard. But again, exciting in that you're taking a disease where you pretty much know you're going to be dead if you're a male by the age of 25, and challenges to look at the females and to understand better why they actually end up presenting more in heart failure. If we switch in conclusion to myosin binding protein C, I think there's two things that happen here. One is that myosin C protein interacts with the myosin head to promote relaxation, and the other it interacts with with actin to promote contraction. So it's very important in several ways, and if it's not functioning, that actually causes all the things that we recognize, the impaired function and the diastolic dysfunction. So the Tenaya have done a mice study. This has been, if you focus, the first part on the left is just dose ranging, but heart function in the middle and survival, and this is a knockout mouse, so this mouse has no myosin, no C protein, and basically if you can rescue that in terms of heart function and in terms of survival, the red line, and the non-rescued, basically they're dead. Now, this is not a great model. These mice die in heart failure, so it's not a great, but I think it is a model. Where we're at now with this particular study from Tenaya, and it's called MyPeak, and these are the 10 centers in America. And they're all American. It's not in Europe at all, and Houston is one of the centers, and it's actively recruiting. Importantly, the first study was a phase 1b, dose ranging, safety, and efficacy. But you can't do this to normal, so it's a slight mushing into one. But it's basically safety to make sure. And importantly, in October there was a review of the safety review, and there was some protocol amendments and a public presentation. And the protocol amendments really were quite important in that it's somebody's perception, whoever reviewed this, that they don't need that the arrhythmic risk from this is low, and they don't need an ICD. The fact that they were not allowed to enter patients with obstruction previously because they were theoretically and reality effective therapies for obstruction, that has been removed as a recruitment problem or a recruitment restriction. So basically the recruitment has been opened up, and the trial is active and recruiting, and so this is in many ways very exciting perspective, because we're going to get proper data. It's now they're still in a phase 1b, they're recruiting, but the phase 2 is in planning. So I think basically, very importantly, the assessment of these patients today, there's only 3 patients data available. So delivery of the DNA is assessed, expression of the RNA, yes, and protein expression, 1. The company they've developed their own assays for these three things, and I think that's going to be important. This is the proof of concept that this is what they're doing is actually working. So this is exciting. It's new, but I think that basically it is on the frontier, and in the end, I think safety is all important. So in conclusion, I think good science, as we know, provokes more questions than answers. The myosin inhibitors potentially offer therapy that will be effective and target fundamental mechanisms. I think there's a lot more to be understood about how they're working and when they don't work, why they don't work, and why they work in patients who don't have obstruction. The gene therapy, I think the data sets are small, and they're, basically we're talking about 7 patients with Danon and 3 or 4 with the myosin binding protein C. But this is a real potential, and I think if somebody had said to me a decade ago, we're talking about a cure, I would say you're crazy. But in actual fact, the safety factors in going slowly and doing this correctly and carefully, and in many ways it's analogous to early transplant days where we made mistakes, hyperacute rejection. We learned, we stopped, or not we, but Shumway and others stopped. But in the end, transplant is a temporary. This is potentially something with long-lasting effect that will be cured of. So thank you very much.
Thank you for the wonderful talk. I think a couple. I mean, it's a fascinating disease state, which kind of gives us the perspective of the genetic coding that can influence, and I'm hoping we can learn as the world opens up technology to look at genetic predispositions of heart failure in general. But I don't know if you can give some insights on two questions I have. One is, we're learning a lot more on post-translational modifications and isomers and isoforms of proteins that exist more than what we thought before. And we're looking at some of this in transplant, and it's fascinating the number of troponin isoforms that exist. And similar to the concept of a variant causing a mixture of efficient and inefficient protein, do you think there is a possibility of disease contribution on post-translational modifications and a mixture of isoforms? Because the whole infrastructure of post-translational modification is another infrastructure. So I wonder, and then I'll ask my next question after that.
So the quick answer is I have no idea. But if we don't consider aspects like that, aspects like polygenic risk, what we have doesn't explain enough of what we see. So there are other factors clearly, and are they environmental? Are they? And I suspect not. I suspect they're more basic in terms of what is actually going on. So I skipped over a little bit about polygenic risk, and I don't know anything about post-translational changes. But I would be looking at, I think, open mind, because we don't explain a lot of what we actually see from knowing the specific mutation.
Thank you.
Yeah.
And the second question might be more straightforward on delivery systems, because I think the AAV9s or AAV systems have worked great, but the barriers of immunity, at least the last trial we did for the SERCA-2A, about 40% of the population got screened out because of antibodies.
Yeah.
How do you overcome delivery systems?
Yeah. So, good point. And when I don't, not part of either of those companies, but I know that they were thinking somewhere that 40 to 50% would get screened out not with the myosin C protein, but with PKP2. They did a study looking at antibody prevalence, and they anticipated 40 to 50%, and I think it was 16% positive, which was a very happy surprise to them. And I think and this was a systematic study of a large number of patients who otherwise would have fulfilled entry criteria for the PKP2 gene therapy trial. So I don't know the answer, but it is an issue, and probably the real answer is somewhere in between those numbers. But it makes recruitment more difficult. One of the nice things that the FDA and the relaxation a little bit on the entry criteria, which I think were draconian safety, but they were, is that relaxation, and then coupled with actually a lower prevalence of pre-existing antibodies, will make recruitment easier, because recruitment for the C protein has been very difficult, and for Danon.
So Dr. Mckenna, just a quick question. I think one of the things that struck me here is what you said is, despite the fact that we have known that this is a genetic condition for decades, practically we're not doing genetic testing in a lot of the patients. And I think we're seeing that now. You can even extrapolate into non-ischemic cardiomyopathy, more and more a genetic cause. Even despite it being in the guidelines, we're still not really doing much, the degree of genetic testing that would probably be beneficial and help us move even more quickly. As you so eloquently pointed out, the genetics really drive the development of the treatments, but if we don't have the genetics, we can't drive the treatments. So how do we get genetic testing in the masses? What are your thoughts of how we increase some of that?
You can't just flick a switch. It won't just start happening, but I think there are a number of initiatives. So the fact that the myosin inhibitor companies, the gene therapy companies are actually commissioning gene testing companies, they're making it available to the centers where they're trying to recruit, is helping to drive the process. It's helping to change practice. I mean, if you're running a hypertrophic cardiomyopathy clinic and you're focusing on getting patients through for alcohol ablation and surgery, having to stop and go through the genetics and the family history and all the rest of it, and it's time consuming, and in the end, you're ending up sending off the gene test to a company. So your hospital is not making, it's not profitable. It's, you're a broker, and you're taking on a legal responsibility, and because say it doesn't work, say the gene test is not correctly done. It's a number of things need to change, and I think the companies are helping. That's one thing. I think knowledge that, and I think I don't like it, but I would have to accept that certainly for the first 10 to 15 years, knowledge of the gene was not actionable. You didn't change your therapy because you knew this patient had this gene or that. With rare, I showed you some of the exceptions. I think that's no longer going to be true. So I think you can present with myosin, with troponin I, and with troponin T, the specific mutation makes a difference. And I know I would put an ICD into someone with this mutation and would reassure and bless the other soul who has the 271 or the non-hinge in myosin. So basically, I think it is happening, but it's not just flicking a switch. It's multiple things happening to change, and it's changing practice. The other thing is that I think age of like the physician, you get into your habits, and I noticed that a lot of the fellows are actually requesting gene tests, and clinicians who are more established in the way they practice are not. And again, it's major referral centers are influencing this. So, but I think it is happening. So a positive view on